Hello everyone. My topic for FS Sureshwar Pandey PG lecture series is foot drop. Most commonly, foot drop is caused by injury to the peroneal nerve, as we all know. Common peroneal nerve is most commonly injured nerve in the lower limb injury. In foot drop, as we know, there is loss of dorsiflexion at the ankle joint, loss of ankle eversion at the subtalar joint, and loss of extension of the toes. The gait cycle contains two most important phases, that is heel strike and swing phase. These two phases are disturbed in foot drop. So in this case, the patient slaps the foot on the ground in heel strike and he drags the toes along with the ground in swing phase. To avoid this, the patient flexes the hip more than the normal to lift the entire foot and the toes off the ground as if he is walking up the stairs. So it is called as high stepping gait. So the definition is it is inability to actively dorsiflex and invert the foot due to weakness or the paralysis of the anterior muscles of the legs. The common causes are traumatic, that is the direct injury, fracture head fibula, lateral condyle tibia, knee dislocation, posterior hip dislocations, acetabular fractures. Metabolic causes include diabetes mellitus, alcoholic neuritis. The iatrogenic causes, that is the tight plaster cast, compartment syndrome, high tibial osteotomy, then total knee replacement, and injection palsy. The neurogenic causes, that is the disc prolapse, quadra equina syndrome, spinal bifida, cerebral tumors. Infective causes includes poliomyelitis, GB syndrome, syphilis, and leprosy. So this is the diagram showing the path of the sciatic nerve, as we all know. The main anatomical features are the peroneal nerve. It is a branch of sciatic nerve. It wraps around the back of the knee to the front of the shin of the tibia. It sits very close to the surface, so it is commonly damaged. So the CPN winds around the neck of the fibula and divides into the two branches, that is the superficial and the deep branches. The superficial branch supplies peroneus longus and brevis and sensory to the skin of the anterior and the lateral aspect of the lower leg. The deep branch gives motor branches to the anterior compartment of the leg and the sensory branch to the first web space. The main muscle supplies are the
Indrajit, we can't hear the audio.
What happened?
The video got paused.
Indrajit?
So have we finished, Indrajit? Yeah.
No, we haven't. It's 11 minute 48 seconds video. I don't know what happened to it.
Indrajit, can you tell?
It may have gone offline.
Sir, I went offline. Some issue with the internet. Just give me a minute.
Okay.
Oh, okay.
Oh, no problems. No problems. So can you? Yeah, you can go ahead.
Okay.
supply. So the main pathology is, according to the Sunderland's classification, neuropraxia, axonotomesis, and the neurotomesis. Depending on these, the severity of the nerve injury, the prognosis of the patient depends. The neuropraxia, the myelin sheath is damaged, but the axons are intact. So the conduction of the nerve impulses is altered at the site of the injury. What we see in the EMG is it reflects as a prolonged latency and the slow nerve conduction velocity. In axonotomesis, the axon is damaged, the epineurium and the perineum is intact. So when nerve is stimulated, these nerves show some sensory and the motor deficit below the location of the nerve injuries. So the recovery is possible in this case, but it is not always complete. The third is neurotomesis. It is the most severe type of injury. All myelin, axons, and the supportive connective tissue are damaged. So there is valerian degeneration distal to the site of the injury. So this is the surgical intervention. In these cases, the surgical intervention is needed in respect to the nerve graft or the tendon transfers. So this is the clinical significance. So what is the history and the clinical examination is? You have to take the careful history. You have to ask the patient to stand on the toes, heels. You have to do the muscle charting. You have to grade the muscle from 0 to 5 from hip, knee, and the ankle muscles. You have to do the neurosensory examination. So what are the types of the foot drop? There are two types, that is high and the low. High is if the level is above the fibular head, that is the involvement of deep peroneal nerve, and the low is below the head, that is the superficial peroneal nerve. So what are the clinical symptoms? The patient is unable to dorsiflex and invert. He drags the foot while walking. He slaps the foot. There are weakness of the muscles. There may be some tingling and numbness. The signs of sweating, loss of hair, or in long-standing cases, you may get trophic ulcerations and vasomotor paralytic signs. How do you evaluate the patient? You have to do the careful physical examination, diagnostic testing, that is, you have to take the x-rays of pelvis, knee, and the ankle joint to rule out any fracture, dislocation, MRI in suspected cases. Musculocutaneous ultrasonography is very important to rule out the swelling at the site of compression. Then EMG and NCV, these are the most important for the evaluation of the nerve. So what the nerve conduction shows is it provides the information regarding the viability of the myelin sheath. What the electromyography shows is the monopolar needles are introduced in the muscles. So the presence of potential called as positive shower waves and fibrillation potentials, which indicates axonal involvement. What is the gait? In cases of foot drop, you get high stepping gait. That is, the normal heel toe progression is lost in such cases. So what are the differential diagnoses? Upper motor neuron involvement, cerebral gait, ataxic gait, severe L5 lumbar radiculopathy, Parkinsonian gait, or diabetic amyotrophy. So what is the treatment for any case of foot drop? After the evaluation, there are two types of modalities of treatment. That is, one is conservative management, second is surgical management. The conservative management includes medical treatment, that is, you have to treat the pain, paresthesia, you have to give anti-inflammatory, then pregabalin, you have to give antidepressant drugs. Second most important is braces and splint. Static and dynamic splits. Stability at the ankle joint, and it provides the toe dorsiflexion during the swing phase. The physical therapy includes the strengthening of the muscles. So now we'll see what includes in the conservative management. The main goal of the conservative management is to stabilize the gait, to prevent the falls during walking, and to prevent the contraction. The electrical stimulation technique is also helpful to prevent the contractures and to prevent the fall while walking. Splinting is also advisable. For complete nerve palsy cases, ankle foot orthosis to prevent the further plantar flexion is useful. Sufficient education and training of the patient should be included in the conservative management. For the pain management, topical analgesics and other modalities are included. So the most important is surgical management. In trauma cases, whenever there is a nerve transection, if you operate within 72 hours in the form of nerve reconstruction or primary nerve repair techniques, autologous nerve graft is performed. For complete nerve compression, nerve decompression should be performed, or a surgical release may be necessary for the patients with equinus deformity. In cases of significant nerve dysfunction, nerve or tendon transfers may be required. So the nerve repair includes epidural, perineural or epiperineural neuroraphy procedures. For tendon transfers, the main aim of the tendon transfer is to improve the stability, to restore the balance, and to provide strength to the adjacent joints. So the techniques are Ober's techniques, Bar's techniques, Kofor's techniques, and Srinivasan technique. The main is the anterior transfer of the tibialis posterior in all cases. So this is Ober's techniques. The medial longitudinal incision is taken. Tibialis posterior tendon is detached from there. Second longitudinal medial incision 10 centimeter long over the musculotendinous junction, and the tendon is withdrawn from the proximal wound and free the muscle belly well up to the tibia. Then make the third incision over the base of the third metatarsal and draw the posterior tibial tendon from the second to the third incision, and it is anchored to its distal end of the base of the third metatarsal. So this is Cooper's technique. The tendon is split longitudinally and the plantar half of the tendon is dissected from its insertion, and it is attached to the peroneus brevis tendon at its insertion. So this is Srinivasan techniques. The tendon is split into two halves and both the halves are attached to the EHL and EDL respectively. In Bar's technique, it is similar to the Ober's, but it is the tendon is attached to the third cuneiform or the base of the third metatarsal. In some of the cases, in long-standing contractures, you may get to do the lengthening of the tender Achilles. In some cases, the bony procedure are required, that is the arthrodesis or the lamellinosis arthrodesis is required. Triple arthrodesis or Campbell's procedure is required in long-standing cases with bony changes and arthrotic changes. Thank you all for your kind listening. Thank you.
Yeah, so thank you, Dr. Indrajit, for playing both those videos.